Great pleasure and privilege to invite my good friend onto stage to talk on non-diabetic hypoglycemia. We've always been used to hypoglycemia due to diabetes. So over to you, Narayanan, for the new aspects.
Thank you, Chairperson. I thank the organizing committee to give this opportunity for me here. So non-diabetic hypoglycemia, as the Chairperson was alluding to, often we talk about the sulfonylurea-induced hypoglycemia and other things. There is a whole host of patients who have got hypoglycemia for other reasons. The list is not exhaustive. I've just illustrated some of them here. The first is, of course, the medication-induced hypoglycemia. This is not only the sulfonylureas and the medications that we use to treat diabetes, but there are also other medications which we need to be aware. One of the common drugs that we use which can cause hypoglycemia is the fluoroquinolones, especially the levofloxacin and gatifloxacin. Levofloxacin being more commonly used for UTIs and other things. These drugs can cause sudden hypoglycemia in a non-diabetic individual. There are also other very well-known causes like long-term starvation, excess alcohol consumption for the reasons like glycogen storage depletion, critical illnesses, CKD, CLD for obvious reasons, that the insulin clearance issues. There could be hormone deficiencies like hypocortisolism and hypopituitarism. But there are certain conditions which are either rare or thought to be rare. So things like insulinoma, the moment we think about an endogenous hyperinsulinemia causing hypoglycemia, the first thing comes to our mind, is there a tumor in the pancreas which is causing the hypoglycemia, which is insulinoma? There are also other rare conditions like IGF-2 mediated. These are sarcomas or mesenchymal tumors which don't secrete insulin but actually secrete IGF-2, which acts at the insulin receptor to cause hypoglycemia. The other one is the autoimmune cause, insulin autoimmune syndrome, otherwise called the IAS, Hirata's disease, named after the person who discovered it, which is often thought to be rare, often described to be only in Japanese population in the early stages. We slowly started recognizing that it can happen in other population too. Of course, more common in Asians compared to the Westerners, but again, even in Indians, it's not as uncommon as people think, and that's what I would focus on. I would primarily give two case examples whom I've managed recently, one of which is rare, really rare, the other one which is thought to be rare, but not actually rare. The first patient is a 27-year-old female from Burma, married at the age of 14, G6, L2, 3 abortions, 1 stillbirth. So she had been undergoing a host of symptoms for 10 years, right from the age of 16 or 17. Giddiness, sweating, palpitations, weakness, lethargy, loss of consciousness, pre-syncopal episodes, abdominal pain, and a progressive weight gain over 10 years time duration. She said she was completely normal up until the age of 16 or 17. She completed the first pregnancy. Then she had the first episode where she presented with profuse sweating. She went to the local hospital, was found to have a hypoglycemia. She was given dextrose infusion. They thought it was just one-off episode for some reason. They couldn't find a cause, gave the dextrose infusion. She was discharged. But eventually, over the years, she started having progressive episodes of this hypoglycemia. She lived in a small village in Burma where they did not have facilities for further investigation. She was not very keen to go to another place for investigation. So she was managed with dextrose infusions on and off. But it got worse and worse and worse. During the 6th pregnancy, she was investigated by the cardiologist because she was complaining of palpitations and intermittent chest pain. All the basic workups were completely normal. Eventually, she went to an endocrinologist in Burma, who did a fantastic job. She was found to have a hypoglycemia of 54 milligrams per deciliter with an associated hyperinsulinemia. The level was 1,901, phenomenally high levels, with the insulin C-peptide ratio of less than 1, indicating that it is an endogenous hyperinsulinemia, that she's not taking it from outside. The endocrinologist there went ahead with imaging. As I was telling, the first thought process in a non-diabetic, in a young lady presented with recurrent hypoglycemia, the classical history of weight gain is whether there is a tumor in the pancreas. So appropriately so, the consultant investigated there with CT abdomen, MRI abdomen, went to the extent of doing an endoscopic ultrasound, none of which revealed any pancreatic tumors. Many a time when we are hunting for insulinomas, many of these radiological investigations can be helpful, but they are not 100% helpful in picking up these tiny, tiny tumors that we come across. Can be helpful up to 80 to 85% time. Still 15% of the time you can miss it on the standard imaging processes that we use. Anyway, because she was having a lot of episodes of this hypoglycemia, she was commenced on diazoxide, then had to stop it because it was not available. Then she was put on octreotide subcutaneous injection, which she was carrying around almost in a day. Whenever she felt like having a hypoglycemia, she would jab herself with 50 micrograms of the short-acting octreotide injection, requiring up to 3 to 6 times every day. She visited Thailand, Indonesia, thinking she could find a solution there. But unfortunately, one of the people there was, she was told that she will die soon because they couldn't find a cause for her hypoglycemia. Given that she's having such recurrent episode, there is no way they could save her. Eventually, she landed up in our hospital. The history revealed that she gained 35 kg in the previous 10 years time period. The basic workup, renal, liver, cortisol, thyroid, everything was normal. That was the glucose insulin C-peptide, which reflected the investigations which she had done in Burma, again confirming that she has got an endogenous hyperinsulinemic hypoglycemia. So we went ahead with localization, thinking whether we could pick it up here, a triphasic protocol with the 320 slice CT, normal pancreas, a whole body PET CT with an exendin 4 GLP-1 analog, which is said to be a very specific imaging, PET CT imaging technique for insulinomas, that also was normal, was not able to pick up any lesion in the pancreas. A diagnostic endoscopic ultrasound, again nothing except for a periportal lymph node, they couldn't find anything abnormal. Again, we are left with a situation where we have known that this lady has been suffering from hypoglycemia. She has got an endogenous hyperinsulinism. We couldn't find where it is coming from. Selective hepatic venous sampling. This is one of the rare things that we do to find out if there is a source of tumor in the pancreas when the imaging fails. What it involves is, so selective arterial calcium stimulation. The gastrodenal artery, splenic artery, and the SMA, you inject calcium. All these 3 arteries are cannulated. You inject calcium one after the other, and then you look, you take samples, multiple samples from the right hepatic vein at 0, 20, 30, and 60 seconds. The idea behind it is, if there is a tumor there, if calcium is infused, that part of the pancreas will be throwing out more insulin compared to the physiological normal pancreatic tissue. Therefore, the increase in the, when you infuse calcium, anyway the insulin levels will go up, but if there is a tumor, the levels will go up much higher. That's the idea behind doing selective arterial calcium stimulation, and this is what she had done. The GDA, SMA, and splenic artery, we could see there is a significant increase when the calcium was infused into the splenic artery, indicating that this could be the source of the hyperinsulinemia in her. And there is a good correlation between which artery is infused and where the tumor could be. If it's a gastrodenal artery, it's the head and neck of pancreas, superior mesenteric, uncinate process, proximal splenic, the tail of pancreas. So based on the the results, we advised her to have a distal pancreatectomy. She indeed had a distal pancreatectomy with splenectomy. The surgeon thought there was a 1 centimeter firm nodule in that side, the distal pancreas. Post-operatively, she was relieved, and we were also, particularly I was very relieved to see that she was not having any more hypoglycemia in the post-operative period. That was the histopathology. We were expecting that 1 centimeter nodule, which the surgeon felt the intraoperative period could be the insulinoma, but it wasn't. The pathologist said it was more of an hyperplasia with some focal karyomegaly. Maybe there could be some occasional islet nodules with focal microadenomas. And they said this could represent what looks like a nesidioblastosis, very, very uncommon in adult situation, except for in transplant patients. In other words, it's termed as non-insulinoma pancreatogenous hypoglycemia syndrome, a very long name for the nesidioblastosis in the children. So just to show that indeed there are other rare conditions which can be very, very troublesome for the patient. Although these are rare conditions, for that one particular individual, finding it out and treating can be a life-transforming situation. When she came to my clinic, she was carrying a box filled with ice with a lot of octreotide in it. She kept injecting it whenever she felt like having the hypoglycemic episodes. And the family got so much relieved. After 10 years of recurrent hypoglycemia, she was able to find a solution. This may not be the end of story for her, given that the histopathology showed a pancreatic hyperplasia. We don't know whether this hyperplasia will start producing it again, but it's been 4 years. She's not come back to us. The follow-up at 1 year, she did not have any hypoglycemia. So that was a rare condition. The second condition is thought to be rare, said to be rare, but it's not that uncommon. This is one of the patients myself and Dr. Venkataraman sir managed together. This is a 39-year-old lady presented in July 2023 with symptoms of hypoglycemia over a couple of weeks time duration, rather a very short time duration. She's not a known diabetic patient. Initially, the episodes were mild, but very soon it progressed to severe symptoms with severe dizziness and pre-syncopal episodes. The episodes were severe enough to restrict her from going out of the house. The whole family was sitting with her because this is a person who was completely active prior to this. She started checking the glucose levels and found to be low. Seen by the GP, she was advised to take frequent feeds, which is appropriate, until they got to know what is happening. She started eating frequently to the extent, even during the night time, she had to take at least every 2 hours food to prevent her from having hypoglycemia, which could be troublesome. Just now we heard about sleep disturbance, how it can wreck their life. And the initial investigations by the GP, the renal liver functions were all normal completely. With regards to endocrine evaluation, the GP did some of the investigations. The past medical history involved hypothyroidism, asthma. The only medication were levothyroxine and some inhalers. She was 73 kilograms, BMI of 30. One of the tests that was done showed a fasting sugar was 45 and an insulin C-peptide was 7.17, sorry, insulin was 219 and C-peptide of 7.17. ACTH, cortisol were normal, thyroid was normal. The CT abdomen was done by the GP outside, which showed a normal pancreas. Sorry, these were investigations we did in Apollo. The CT abdomen was done by the GP before even she came to us. The GP obviously looked for whether this could be an insulinoma, and there was no tumors in the pancreas. Well, learning from the previous case, we couldn't find a tumor. There could be a tumor in the insulinoma, but as we saw from the first patient, in a typical insulinoma, the history is rather a longer duration. This would have developed over a period of months, at least to years, where they might have developed a frequent episode, progressive increase in weight gain, which we all saw from the first patient. This lady had a very short duration, 2 weeks duration, progressive increase in the frequency and severity, which is not typical for a patient with insulinoma. And hence, we sent off some insulin antibodies, and we were waiting for the antibodies. I commenced her on prednisolone 40 and acarbose 25 milligram. Prednisolone with an idea that if it were to be insulin antibody syndrome, it would suppress the immunity. Acarbose would delay the hyperglycemia, the postprandial hyperglycemia, which will alleviate the hypoglycemia. And as we expected, the insulin antibody levels were phenomenally high, more than 300, confirming the clinical suspicion of insulin antibody syndrome. There are a number of triggers that could trigger an insulin antibody syndrome. In the typical Japanese population, they said it is spontaneous, need not be a trigger, but in other population, including in Indian population, we do come across some of the triggers which can cause this. These were the medications that she was on, none of which were prescribed medications. Some garlic capsules, imported multivitamin tablets, Renerve capsule, which she had been taking for nearly 3 to 4 years time duration. This is a list of triggers that can trigger an insulin autoimmune syndrome, and this is one of the supplements that she was taking, alpha lipoic acid. For all our practitioners, we prescribe Remylin, Reno Plus, and people tend to take this for a very long time. I mean, typically, these are things which are given for peripheral neuropathy, but we do see the prescription goes on for years together. Even innocuous medications like alpha lipoic acid can trigger, like in this patient. 3 months down the line, the insulin antibody came down to 31. Her clinical symptoms resolved, and she was eventually weaned off all the medications, acarbose, steroids, everything. So just a brief note on the insulin autoimmune syndrome. The reason I'm discussing this is thought to be rare. I mean, we look at the literature, but it is not that uncommon. I have had at least 3 patients in the past 4-5 years with insulin antibody syndrome proven. So the first description was in 1970 by the man Hirata. He described this as a hyperinsulinemic hypoglycemia, elevated antibodies, no prior exposure to exogenous insulin, and no pathological abnormalities of the pancreatic islets. As I said, it's more common in Asians compared to Westerners. 90% of the world cases until 2009 were reported from Japan. And journal in 2018 reported that only 2 cases have been described in India so far. I'm sure many would have experienced more cases. The mechanism of insulin antibody syndrome is this is an autoantibody, more often an IgG, but sometimes it could be other classes like IgA2. And this binds the insulin, it gets bound, the insulin gets bound to the IgG antibody. Once it gets bound, there is no action. The hyperglycemia, the postprandial hyperglycemia will stimulate further insulin secretion from the pancreas. Therefore, there is a postprandial hyperglycemia, elevated insulin levels, most of which are bound to the IgG antibody. Once the IgG antibody is saturated, the excess insulin starts bringing the glucose down, the pancreatic insulin secretion stops. Suddenly, the bound insulin gets released, which causes unexpected hypoglycemia. That's the mechanism behind the hypoglycemia with the IAS. The hypoglycemic attacks can happen after physical exertion. Sometimes they can present very much like what we call as the reactive hypoglycemia, typically 3 to 4 hours after the meal. People can present with sudden onset syncopal episodes. There could also be atypical presentations like sudden onset seizures. The frequency increases over time and can be associated with other autoimmune syndromes too. The diagnosis first prove the Whipple's triad, prove the endogenous hyperinsulinemia, that it is not an exogenous insulin-induced hypoglycemia. Insulin levels are typically high. C-peptide can be normal or high. The HbA1c levels are variable because they do get a postprandial spike in sugars, then a fall in glucose level. So it's an average. So HbA1c can either be normal or it could be on the higher side. Insulin antibodies are the only reliable test. Often the levels are more than 150, like in our patient. Imaging is useless, but it probably could be needed to rule out other conditions. And these antibodies are heterogeneous. It's important to understand that most of the commercially available kits which measure the insulin antibodies measure only the IgG class of antibodies, not the IgA or IgM antibodies. So sometimes you expect IAS, you could get a falsely negative insulin antibody levels that does not rule out IAS. If the clinical picture fits in, then we should treat. Treatment in Japanese, they said it's often self-limiting, few months with withdrawal of the triggering agent. It could be the medication, could help. Small frequent meals with low carbohydrate content. Cornstarch, acarbose does the same job of ameliorating the hyperglycemia postprandially. Steroids, like in our patient, or steroid-sparing agents like rituximab, azathioprine, somatostatin analogs, diazoxide. In severe cases, plasmapheresis, intractable hypoglycemia, we do not know what else to do, then a pancreatectomy. Recurrence uncommon, less than 5%. Recurrence can occur even after 1 year after resolution. Re-exposure to the triggering agents can cause recurrence, but recurrence can also occur without any triggers. Therefore, no clear strategy can be told to the patient as to when should be the exact follow-up after that. I think probably I'll stop. This is the slide regarding evaluation of hypoglycemia. We've run short of time. I'll take the questions at the end. Thank you.
The help of Narayanan to sort out this issue in which he has an experience, and the results are so overwhelming. I wanted the audience to be exposed to the success of this. This is not at all that rare as we tend to imagine. I think thanks Narayan for the wonderful workup and then agreeing to present on behalf of myself.
Thank you. Thank you for the opportunity, sir.
Thank you.